This is my chronic care case presentation. The patient we saw was a 56-year-old male, Native American with existing diagnoses of HIV, gout, type 2 diabetes with neuropathy, GERD, obesity, alcohol-induced necrotizing pancreatitis with pancreatic insufficiency. And social history included working for a nonprofit organization as well as his Native American tribe, being a former smoker, former IV drug user, and former alcohol user. However, he at this point has not used any substance in a very long time. Most of his conditions are currently well controlled, besides his type 2 diabetes, which recently became uncontrolled. He is currently on metformin 2,000 milligrams daily, which was increased back in August. And he had previously, prior to that, been diet controlled. His necrotizing pancreatitis recently has worsened and is managed by GI. He is currently on Creon 3 times daily and recently had a transluminal drainage and an attempted cholecystectomy. However, they found it to be technically not feasible, and at that time found a disconnected pancreatic duct as well. Recent events prior to me seeing him was a recent hospitalization for acute on chronic pancreatitis in early August. He did have a hospital follow-up with my preceptor in late August, at which time lab work was ordered, and then a follow-up GI appointment. The lab work that was ordered was a lipid panel, and then she did review his most recent hemoglobin A1Cs, which 7 months ago was 6.5 and diet controlled, and then 2 months ago had increased to 10.4, at which time metformin was started. GI thought his chronic pancreatitis to be due to both his alcohol use and gallstones. And then given the cholecystectomy was not feasible, they recommended an ERCP procedure. The first visit I saw him for was in September via virtual visit, at which time we discussed his fasting lipid panel that was previously ordered, showing very elevated triglycerides at 705 and low HDL at 27. Of note, a year ago, his lipid panel was relatively within normal limits besides low HDL. His triglycerides at that time were 111 and HDL was 32. Vital signs were mostly not able to be attained during the virtual visit. However, his physical exam was within normal limits. Differential diagnoses include high triglycerides. We thought the dramatic increase in triglycerides most likely was secondary to his recent bout of pancreatitis. He was agreeable to starting medication. The ERCP procedure GI had recommended was scheduled for the week following, and we discussed beginning fenofibrate 160 milligrams PO daily due to its target on triglycerides specifically, and then wanted to recheck his lipid panel in 2 months. We did briefly mention a preventive cardiology visit if needed in the future, depending on his follow-up labs. And then dyslipidemia, we're considering starting a statin. However, we will determine that based on his follow-up labs and just keep an eye on his low HDL because that has been chronic. Type 2 diabetes with polyneuropathy. We have plans to recheck his hemoglobin A1C with his lipid panel recheck in 2 months, which will get us to 4 months following his last hemoglobin A1C. We decided to continue them at metformin at 2,000 milligrams daily and gabapentin at 300 milligrams TID, and then we'll consider a referral to medication therapy management with a pharmacist pending results, which is a great tool Fairview has, and it just helps primary care physicians continue to manage diabetes and make sure everyone's on the same page and labs are getting done and medications affordable. And so it's a great tool to have. Interim events included the ERCP procedure, which had no issue. Patient reported no issue starting fenofibrate. He reported no hospitalizations or recurrent pancreatitis symptoms. He was checking his blood sugar at home, however, only a few times a week. He denied it any hypoglycemic events and continued his metformin without issue. However, he does report feeling increased urination and increased thirst as of late. Visit 2 was in person and was to follow up on diabetes and elevated triglycerides. It was in November, about 2 months following his virtual visit. His fasting lipid panel was improved. However, his triglycerides were still elevated at 483 and his HDL was still low at 31. However, his hemoglobin A1C was significantly elevated at 15%, which equates to an estimated average blood sugar of 385, which was increased compared to his previous hemoglobin A1Cs. At that time, his vitals were stable and his physical exam was unremarkable. Differential diagnoses include his previous diagnosis of type 2 diabetes. However, we suspect this is actually diabetes type 3C, pancreatogenic diabetes, given the severe progression of his A1C despite no significant lifestyle changes. His A1C was significantly elevated at 15%, and we suspect this is secondary to his pancreatic disease / pancreatic insufficiency. Because of this, we placed urgent referrals to endocrinology and a diabetes educator, as well as ophthalmology for an eye exam. We discussed the fact that he will most likely need to start insulin therapy and would benefit from a continuous glucose monitor, and in the future possibly require an insulin pump. For his alcohol-induced pancreatitis, he is currently sober. He's currently not a smoker. His recent ERCP procedure went well with stent placements, and he follows with GI for that. For his high triglycerides, although they are better, they're still elevated, likely due to his elevated A1C. We suspect sudden significant elevation due to pancreatogenic diabetes progression, and we ideally hope this will improve once his A1C is better managed. He is tolerating fenofibrate, so we did continue that, and we are referring to endocrinology, and we'll consider a cardiology referral in the future if needed. We were and are still considering starting a statin given his current conditions. The coaching techniques we used were active listening and motivational interviewing. We were able to determine EJ's stage of acceptance and motivation to improve his health. And we found that he was expressing change talk. He had already started taking steps towards change with lifestyle modifications, which was great. So we affirmed his efforts and worked as a team to determine next steps that he felt comfortable with, which were referrals to all those specialists mentioned previously. A little bit about diabetes type 3C. It is secondary to pancreatic diseases. It occurs due to the destruction of islet cells, leading to the loss of insulin secretion and the counter-regulatory hormones like glucagon and pancreatic polypeptides, most commonly due to chronic pancreatitis. This causes significant changes in blood sugar that are hard to manage, and due to the impaired counter-regulatory hormones, as well as insulin secretion, this can lead to a higher likelihood of treatment-induced hypoglycemia. The treatment of choice is metformin, as it has been shown to also reduce the risk of pancreatic cancer. However, insulin is often needed for these people. DPP-4 and GLP-1 medications are avoided due to the risk of acute pancreatitis with them. And additional considerations for these patients include optimizing diet due to the malabsorption they are already likely having to avoid malnutrition, and management of underlying pancreatic diseases. Conclusion and discussion, the ethical and cultural considerations. EJ is a very busy individual working for his Native American tribe, as well as a nonprofit organization for which he spends time traveling, which causes him to eat out more often than he would like. However, this work is what drives him. It's what motivates him. It's what keeps him sober. So it is not something he's willing to step back from or reduce. However, he does feel things will slow down come the next year. He reports feeling a little overwhelmed recently with his procedures and worsening lab work, but feels he can be doing a better job in terms of diet and exercise. The cost of insulin and his medications are always a consideration and something we kept in mind during this time. The impact of this chronic illness. EJ has a loving and involved fiance who was present at each visit. She's supportive and ready to help with meal planning. Although both EJ and his fiance are wary of starting insulin, as it feels daunting to them, they are both motivated to keep EJ healthy. They're aware insulin will be lifelong, but express feeling supported by their current healthcare providers. And they also express feeling empowered to learn how best to manage this new stage of EJ's health, and are happy with having a plan moving forward. In terms of coordination, multiple specialists are now on board, including his PCP, GI, diabetes educator, and endocrinology, with discussions of potentially including cardiology in the future. Community resources utilization, we were able to get EJ set up with a diabetes education pharmacist, which helped him review the use of insulin, how to carb count, which insulin was best covered for him, the instructions on attaching his Dexcom, how to meal plan, how to problem solve with hyper and hypoglycemic events. My preceptor, the patient, his fiance, and I share decision making. In this case, I therefore cannot say any contribution was uniquely my own. If given the opportunity, I would probably have initiated a statin prior to considering a cardiology referral. However, I do feel holding off to prevent overwhelming EJ was reasonable. End of life planning did not occur at either visit. However, EJ does have a healthcare directive on file, and there were no language barriers. And here are my references.